The value of MRD, I think nowadays is beyond any doubt. It is well demonstrated. It is there, this ASH in one plenary and in another late-breaking abstract. The problem is that we are seeing that from the prognostic point of view, the value of MRD relies much more on its kinetics rather than a single assessment. Kinetics are much more informative. Obviously, kinetics require consecutive bone marrow aspirates, and this might be feasible in clinical trials when you have pre-specified collection of samples. But consecutive bone marrow aspirates are a barrier for the implementation of MRD outside of clinical trials in the routine practice. And this is what pushed us to develop and test methods for minimally invasive MRD assessment. Very briefly, what we will show at ASH is that probably the combination of mass spectrometry in the serum and flow cytometry in the blood may achieve the complementarity, the synergism between the two techniques and the sensitivity to replace bone marrow aspirates. Importantly, not in all patients nor in any treatment scenario. We are focusing particularly in patients that are either receiving maintenance therapy or under observation if treatment is not being given until disease progression. In this particular setting, I honestly believe that we might achieve a scenario where bone marrow aspirates can be performed every 2 or 3 years and in between more frequent blood testing.